Pleased that as the morning has gone on, a lot more people have joined us in the room, because I think it's really very important that you're here for this next session. It's about combating racism in nursing. It's a Tri-Nations perspective. It's a piece of work that's being done across the world with a number of nations involved, but I'm not going to talk any more about it. I'm going to introduce the panel who are here with us. We've got Adjunct Professor Karrie Long, who's the Chief Nurse and Midwifery Officer, Safer Care Victoria, Dr Ali Drummond, who's the Chief Executive Officer of the Congress of Aboriginal and Torres Strait Islander Nurses and Midwives, and Professor Sabina Knight, who's the Director, James Cook University, Central Queensland Centre for Rural and Remote Health. They're all here with us in person on the stage as we speak. We've got two virtual attendees for this session, Lorraine Hetaraka, Chief Nurse, Ministry of Health, New Zealand Government, and Nadine Gray, who's the National Chief Nursing Officer in New Zealand. We were hoping to have two other people join us who are part of this work. They're here in spirit but unable to be online or in person, and that's Professor Lynore Geia, Professor of Nursing and Midwifery at Edith Cowan University, and Professor Sue Tranka, who's the Chief Nursing Officer of Wales. So please join me in welcoming our speakers and thanking them in advance for bringing this important work to us today.
Got sound? Yes, grand. Good morning, everybody, and thank you for coming after a joyous night of dancing last night and being here this morning for this really important conversation and, might I say, call to action. So while you're sitting here and listening to the different perspectives from multiple nations around racism, we will be asking you at the end of this session, what will you do when you leave today in the spaces that you occupy at work in your community to address racism? So we come to you today across three nations, nurse leaders committed to addressing and eradicating racism. We know it's vitally important to dismantle systemic oppression in health. As a coalition, as a group, we pitched this proposal to the ICN, to Congress in Helsinki just last month, and unfortunately it wasn't accepted. Congress in Montreal 2 years prior had a very early morning session where the Black nurses of Canada and the USA came together, and we had a really fabulous and important discussion about the importance throughout our profession and professions, including midwifery, around addressing racism, not only for those that we serve, but within our profession. When our abstract wasn't accepted by ICN, we reached out to ACN and felt that it was vitally important to have this conversation here and with you. And they showed great leadership in giving us the keynote in the very last day to do that. So, I would like to acknowledge the people of the Ngunnawal people on the lands on which we are standing today, and I also acknowledge the Kaurna people on which the lands that I was born, and the Wurundjeri people on the countries that I work. Victoria's recent experience with our Treaty and Truth-Telling Europe Justice Commission shows us and tells us the work that we need to do in addressing racism in our state in particular. As Victorian CNMO, I am located in our safety agency, and what we recognise in safety is that being different and exploring our differences is a strength, and coming together and building a system that addresses and responds to our differences is important, and that's no more pertinent than it is in this conversation. And I would like to acknowledge people's different lived experiences of racism in your lives and in your professional careers. So we are gathered today to start a movement, or to resuscitate, from a good nursing term, a movement and collective action across Australia, New Zealand and Wales in addressing racism. The purpose of today is to have your nurse leaders here that are addressing these challenges daily. And I have heard and seen in posters people really trying in their organisations and places that they work to address racism, and that sometimes their leaders have been quiet. So we stand here today to say we are not being quiet and we hear you, and together we can do something about this. I think for me, coming back to courage, compassion and connection is really pertinent for this topic, and in particular, might I consider that courage, compassion and connection might be our antidote to racism. Racism is personal. In this picture, that tall girl there is actually me. And the reason why I share this picture to you is I was very fortunate to grow up in Papua New Guinea. And what I learnt as a white girl of privilege growing up in Papua New Guinea was that the Papua New Guinean people showed me as somebody who was different and in a minority. They met me with love and wonder. And for me, that was very powerful. And I know today in Australia, where we have people that feel different, look different, our First Nations people, I challenge we meet them with love and wonder. So this experience was pivotal for me in becoming a nurse and in what I do every day, and why I'm standing here today and attempting to bring great people together to take action. In my conversations as a government chief nurse and midwifery officer, I reach out and have many conversations across the world, and in my conversations with my colleague Sue Tranka in Wales, who is the first chief nurse of the global majority in the UK. She has done amazing work and really wanted to showcase and invite her, and unfortunately she had a ministerial priority that prevented her from joining us at midnight in the UK today. They've done some amazing work in Wales. They have a whole of country anti-racism approach through all of their policies. What Sue and her team have been able to call out is the disproportionate representation of nurses from the global majority in early career roles, in applying for positions, and in particular, that white colleagues are 90 times more likely to be appointed to executive roles than global majority colleagues. And when in the world we are relying and inviting nurses from other countries to come and work with us, this will be a vital piece of work for us all to adopt. In the work that Alison McMillan and I led on the National Nursing Workforce Strategy, to Senator Rushton's view, we did consult widely. We travelled around the country. We sought consultation from over 6,000 nurses, educators, policy people, consumers, students. And what was very clear was that racism is a very real issue within our profession and in experience of our consumers. And you will see in the work that we have published documenting those consultations that racism is there and seen in black and white. And that's pivotally important. Sorry. I think for me, the takeaway as that National Nursing Workforce Strategy works its way through the Prime Minister's office and through its many processes, there is still work to be done. In the work that I have led across Victoria, leading a ministerial task force into our maternity services, I have seen and heard and actually noted silence as well. So where you don't hear it, look for it, of systemic racism and oppression and disadvantage amongst women and families. And it cannot be ignored and is absolutely something that we need to commit to. So in reflection, as I move on to Sabina to take over from next, I really bring this back to a personal perspective and reflect in the work that we did in the task force in Victoria as I travelled 2,500 kilometres listening to stories. I reflected very personally that in 1971, when my mother gave birth to me on Kaurna country, on Yorta Yorta lands, Indigenous and Aboriginal women gave birth on the verandas of hospitals in Victoria. And so I really have a call to you to look and listen and act. And Sabina Knight needs no introduction, but she will do the same. So I'll hand over to Sabina. Thanks.
Thank you, Cowan. Thank you very much, Karrie. And I too would like to acknowledge the traditional owners, the Ngunnawal people here. I would like to acknowledge our Indigenous nursing colleagues here in the room today. I was born on Kamilaroi country, but I live and work now in Western Kangaroo. Racism is incredibly hurtful and dangerous. It's expensive and it's deadly. It's a very high cost to our health workforce by inhibiting or prohibiting or preventing the best efforts of people who are experiencing racism, and in particular, but not only, Aboriginal and Torres Strait Islander nurses, and if we listen closely to them, experiences that they have really impact on where they work, on what they can do and how they feel about themselves. And it has incredibly high cost to patients. We have therapeutic nihilism, alive and well, where our unconscious bias and conscious bias excludes people from treatments that would otherwise be offered because of an assumption that people are not compliant, are not suitable. There's a whole range of reasons why, but we know the evidence is very strong that right across our health system that we have these biases which excludes people, which then impacts on their quality of life and length of life. It's something that we just cannot accept. And so whilst we are the most trusted profession, within some groups of consumers in Australia, we are not. And we really do need to examine ourselves and that issue and say, well, how can we re-establish that? That is hard work that we need to do. You read and you hear the coroner's inquiries that are reported, several each year, for which clearly articulate that as nurses we have failed to recognise the clinical presentations, the humanity associated with the presentations, and have disregarded people trying to access our services where we are at the front line of those services. And so we absolutely must learn, as an evidence-based profession, learn from these and address these. And these are not unusual outlying events. Way too many are occurring. And so we have to take the bit between our teeth and absolutely address this. So who are we? So please don't take a photo of this. I promised Maureen that we wouldn't. It's not yet published, but hot off the press for her in the department here is the 2024 data that tells us that just under 50% of nurses in Australia were born overseas. And that is now reflecting our population, yeah? And so that's good. 48% of nurses employed in Australia, that important difference that we heard, were born overseas. And 26% of nurses in Australia achieved their qualifications overseas. So we've got people who were born overseas but did their nursing in Australia, but a quarter or maybe more, because there is some missing data, achieved their qualification elsewhere and came to work in Australia. So we represent an enormous diversity in the workforce. We don't yet represent our populations, but we are getting there. So where do we come from? Well, rather than the countries or the large groupings of countries, we are from conflict zones, we are climate refugees, we are economic refugees, we are seeking opportunity, we're seeking a better life, we're seeking adventure, and we're seeking security. And as nurses, one of the things that we do understand is that we really have to take a careful history in order to be able to develop a management plan that's appropriate for this patient and this client in this circumstance. And so knowing about people is really important. So if we're in the aged care sector or the disability sector, for example, and people are coming into institutional care but have been grown up in institutions for which they were abused, there will be enormous fear, terror in fact, of entering those institutions. And unless we are thinking about this, we are not going to be able to be our best selves with them and all of the reassurance we need to do, or being hyper alert to their anxieties. And I'm using this just as an example. It happened to a very good friend and colleague's mother recently, who was an orphan and grew up in an orphanage, had the usual awful experiences in orphanage, and with dementia, her biggest fear was realised and needing to be institutionalised. But people who've been prisoners of war, people who've had other experiences, we need to be really mindful of their experiences, where they're from, who they are, but importantly, our colleagues as well. And we had one of our own esteemed colleagues, Professor Lynore Geia, who gathered people together in the post-era of Black Lives Matter in 2020 and wrote the Sentinel article with 100 co-authors in a unified call to action. And I strongly recommend this to you if you have not read it. As students, please absolutely make sure you read it. As educators, as clinicians, as service managers and organisers, there's something in this for us all, and it is a really important piece of work. Because she, and I don't want to not quote her well here, but as she says, and we know this is our lives, that the apathy and conversational tones of casual racism here in Australia, that they are ingrained. Indifference and irreverence of the humanity of Indigenous lives resounds in our private and public spaces and face-to-face interactions, at barbecues, at dinner tables, in classrooms, in shopping malls, in universities, in churches, and in Parliament. Racism divides Australian citizens. And we saw only last week a young man with disability, very similar to my foster son, tackled in a shopping plaza because he had stolen some meat or some biscuits, I can't remember what it was, and he died because the off-duty police officer sat on him. As I said before, we have both professional responsibilities and a very privileged position of trust. We have codes of practice, codes of ethics, education standards, we have regulation. And we saw last year, or early this year, for the first time, another health professional colleague deregistered on the basis of racism. And so it is critically important that we use the standards that we have to be able to improve the standards that we desire. We are committed to social justice and evidence-based practice. Our revised definition embraces that. As Australians, this is really important to us. And so at the individual level, we understand this importance of comprehensive history, as I was saying before. So we need to know the history of where we are and where we're working in order to be able to understand whose shoulders we're standing on. They may be giants, but they also may be people who have had seriously disadvantaged and diminished people trying to access services. As we say, having to give birth on a veranda, having to have your child admitted with the diagnosis of neglect, which is absolutely not true, but we had whole wards full of those when I was a young nurse. Just not true. Children with acute diarrhoea and dehydration living without any access to fresh water, clean water, public health issue 101, diagnosis neglect. So we have a history, nursing and midwifery, of complicity in racialised discourses and practices. Fact. Okay, what are we going to do about it? We absolutely need to move forward. And as Lynore says, we can no longer accept this discourse that I treat everyone the same and I don't see colour and all lives matter. Because if you treat everybody the same, you disadvantage anybody who's not the same as you. And as we saw, Black Lives Matter, the movement initially energised a global stance to dismantle the structures of racism. But then came the backlash. And we are still in that backlash. So I will come back to you in the end with a call to action, but there are so many opportunities for us. But we, only us, in nursing, all of us can deal with this. So I'd like to now pass over to our colleagues in Hetaraka, Lorraine and Nadine, and if our colleagues could bring them up on the screen. Kia ora.
Tēnā koutou tātou ngā rangatira mā. Ko Nadine Whenua, he pia hau o here. It's lovely, the National Health New Zealand. Kia ora koutou. Ko Lorraine he hau, he uria hau ki Ngāti Kahu, Karawa, Maitirangi, Ngāti Kahu. It's amazing with you. I apologise for the way here from Wellington before that we're here with you. I'm actually just speaking on it, but we've got three of you. Anyway, I thought I would start off by our first slide and providing a bit of context, a bit of a snapshot around Aotearoa and New Zealand.
Next slide.
So we have over 5 million people here in Aotearoa, New Zealand, and we service them with our fantastic nursing workforce, which is made up of 85,000 registered nurses with an annual practicing certificate. Importantly, not all of these nurses are working and practicing in New Zealand, so we do have a number of nurses that hold an APC or an annual practicing certificate here in New Zealand but not working here. This time last year we had seen 78,000 nurses, but interestingly we've seen an increase of 6,000 nurses, which is about 9% increase over a year. About 46.6% of our nurses are internationally qualified nurses, so similar numbers to Australia. And our nursing workforce is made up of 2,459 enrolled nurses, 82,000 registered nurses, and we have about 897 nurse practitioners. Māori are Aotearoa New Zealand's Indigenous nurses, and they make up about 7% of our total workforce. However, our population here of Māori Indigenous people sits at 17.7% of our population. And Māori are a growing population, and it's expected to surpass 1 million by the early 2030s. So a key highlight here is our Māori Indigenous peoples are growing, and they are a youthful and younger population. Similarly, Pacific nurses make up 3.9% of our nursing workforce, and our Pacific people here in New Zealand make up about 8.9% of our total population, and they too have a median age of 25 years and a younger population than our national population. Pacific peoples are the fourth largest major ethnic group in New Zealand after European, Māori and Asian groups. Diversifying and growing our Indigenous Māori as well as our Pacific nurses is a key focus and one way we can support the delivery of culturally appropriate and importantly safe care. I'm just going to hand over to Nadine.
So we think it's important to set a bit of context around some of the changes we've experienced from a political perspective in Aotearoa, New Zealand. So one of the largest system reforms in the history of New Zealand commenced in July 2022 with the High Order Act coming into effect under the then Labour government, which saw the disestablishment of 20 district health boards and the centralisation of our health system into one national organisation, which is Health New Zealand. And it partnered with Te Aka Whai Ora, a Māori health authority. The Ministry of Health, where Lorraine's role sits, retains its function of leading policy, strategy, regulation and legislation. So Te Aka Whai Ora, the Māori Health Authority, was charged like a guardian, a kaitiaki, with bringing transformational change to the health system, particularly to address intergenerational inequities in Māori and the Indigenous people's health. It was a once-in-generational opportunity to do things differently. And really, when we think about the origins of Te Aka Whai Ora, it was simply due to a document signed by our tupuna, our ancestors, in 1840. The Treaty of Waitangi was signed and negotiated between Māori and the British Crown that affirmed Māori sovereignty and guaranteed the protection of health. And I should note here that New Zealand has a single jurisdiction situation with a single treaty, and we want to acknowledge that other Indigenous territories may not have the same. I've also got here on the slide Te Mauri o Rongo, or the New Zealand Health Charter, which is embedded in the Pai Ora legislation, and it speaks to the 4 pillars or the 4 po of our values within our health system. And really this is to how we relate to each other to serve whānau and community, how we continually improve the health outcomes and contribute to Pai Ora, a healthy future, and that we embrace and protect a common purpose when we are trusted in the lives of other people. And within that is an anti-racism agenda. Next slide. However, the political pendulum swings hard and fast in New Zealand with a 3-year political cycle, and we had a change of government administration in 2023. We saw fast-track legislative changes, and Te Aka Whai Ora was disestablished on the 30th of June in 2024. Since then, government departments in New Zealand have changed to English names in all branding and decisions for healthcare, and the system is based on need, not race. So it has been quite a hard swing here. So this change meant that Haora Māori, or Māori Health, is now embedded as one function within Health New Zealand, no longer a standalone entity.
Next slide.
So this slide just really frames inequity in Aotearoa, and I guess to Sabina's discussion around inequities are expensive and they are deadly, and our Indigenous population, our Māori population, have enduring inequities, and particularly a shorter life expectancy than any other population in New Zealand. So it really does require us to deliver, healthcare in an increasingly complex environment, but we all have to do this, focus on inequities together to actually realise change. Next slide, please. So, the story of the bee. We encourage you to really familiarise yourself with the work of Professor Kamara Jones and her analogy of the gardener, and also you could think about the bee. So, like telling stories of the bee, a story of a bee, it can help initiate conversations about systemic racism and bias and its impact on health. Next slide, please. So every bee, each one of us has an important role to play in naming racism, building connection in our profession, and investing in cultural safety training to look at our own selves and how we can impact inequities across our health systems. We're all leaders in the conversation. Professor Kamara Jones talks about everyone having the opportunity to achieve good health. And by initiating these conversations, we will actually make a collective impact. And so probably one of the most important pieces of work from a nursing perspective in Aotearoa has been the implementation this year of the new standards of competence and new scopes of practice for both our registered nurses and enrolled nurses here in New Zealand through the Nursing Council of New Zealand. So the new standards emphasise 6PO, which you'll see in the diagram. What's important to call out here is that the changes are designed to ensure that nurses in New Zealand are equipped to provide safe, effective and culturally safe care in a really dynamic healthcare environment. It talks about leadership in nursing, encouraging nurses to act as change agents and advocate for improvements in care delivery. It also talks about social justice, and again, back to the B, that we all have a part to play in our competence in the delivery of care and how we do that. Hilda.
Good morning, everyone. Sorry, I've got two mics on, so I've got to choose which one. A great way to start the morning, talking about fighting racism. Wonderful to be here with you all on the amazing non-well-membered country. My respects to elders past and present. I'm grateful for me to have this opportunity to take part in this important conversation. Unfortunately, Professor Lynore couldn't join us today. My focus will be the Australian context, of course, and specifically the experiences of Aboriginal and Torres Strait Islander people. I will look to some framing offered by Professor Sir Michael Marmot to scaffold my presentation. In his 2016 Boyer lecture titled Health Inequity, The Causes of the Causes, Marmot, a globally recognised advocate for social determinants of health, highlighted that there are three factors that needed to address health inequity in the world: the know-how or knowledge, means or the resources, and will. His argument was that generally the world has the knowledge of what it takes to address health disparities, highlighting the significant advancements in health medical research and their application. Although access to best knowledge and technology varies across the globe, and of course we know in Australia it varies across our continent. He argued that we have the means or the resources to address the limitations of people's access and experience of social determinants of health, including access to quality and safe education, employment pathways, good wages, appropriate housing and transport, etc. Although he highlights that the way that we are okay with the maldistribution of resources globally, where some individuals earn as much as small countries, is problematic and is definitely a primary condition to inequity. He argues that we lack the willingness to act based on the knowledge we have to resolve inequality and equity, including poor health, that the inequity in access to adequate resources is by design, and that our collective global will lacks integrity, despite our thoughts and prayers for the most needy. Perhaps what Marmot could have highlighted more in his lectures are the manifestations of racism that relate to all three of these factors. So here I will present a brief perspective on how his three factors relate to the experiences of inequity of Aboriginal and Torres Strait Islander people, highlighting the operations of racism, and allow for reflection on the potential role of contemporary nurses and how we could address racism and inequity. So knowledge. While we have advanced knowledges in health and social determinants of health, we remain generally lacking in the understanding of contemporary operations of racism and how it informs poor practice when it comes to caring for Indigenous peoples. We lack knowledge in other areas, of course, for example, Indigenous knowledges about well-being and health, but today I just want to focus on racism. Racism has been identified time and time again as a significant factor in poor health for Indigenous people, so we must address it. But how many of us in the room can say we have a really good understanding of interpersonal and institutional racism. How many know how to step in and address racism, de-escalate a situation in a way that protects the victim? How many of you work in health and education services that have supportive policies and procedures for reporting and resolving racism? Do these policies and procedures support the victims of racism? Race and racism, they're both grounded in Western theology, art, philosophy, and science. It is how the West learnt about the peoples of the world, seeing humans through a racist lens justify the colonization of other countries. This technique of dehumanizing people to justify harming and killing them remains successful today, and we see that happening in Gaza. Racism was used previously to kill, contain and control Aboriginal and Torres Strait Islander people. We were the first peoples of these territories, thus dehumanizing us was essential to colonization. Noble savages we were in territories, and our territories terra nullius, just up for the grabs apparently. Florence Nightingale had an interest in the impact of colonization on Indigenous peoples, especially children. She was working with a missionary in Western Australia to document Aboriginal child mortality in Australia during colonisation, and evidently was the worst of any British colonies. She seemed to see British colonisation as unavoidable, and that her role was to advocate for a less harmful way of colonising. Racism is plainly evident in the historical exclusion of Aboriginal and Torres Strait Islander people from the nursing profession, and the scholarship of Professor Odette Best brings to light some of these stories, all the way from the beginning of 1900s. And of course, CATSNM invests in this important truth-telling as well. Today, Aboriginal and Torres Strait Islander people are encouraged into profession. However, the racism that is encountered by students and practitioners highlight that there is more work that we need to do. We must be knowledgeable to be able to confront our history and our contemporary practice of care. Unlike Florence, we cannot just advocate for less harmful ways of colonising. Instead, we must demand equity and justice for Aboriginal and Torres Strait Islander people. Means and resources. The lack of knowledge impacts on how we invest in Aboriginal and Torres Strait Islander people and our health. In their critique of the implementation of the first Closing the Gap agreement between all Australian governments, the Australian Human Rights Commission highlighted a number of flaws, including, and importantly, that there was no actual real implementation, but also they found this belief in the Australian public that it was unfair to spend more on Aboriginal and Torres Strait Islander people than it was on non-Indigenous people's health. It is true, in the years to 2020 and 2022 and 2023, that for every dollar that we spent on non-Indigenous peoples, we spent $1.30 on Indigenous people. So yes, the amounts are not the same because we're aiming for equity, not equality. We want same outcomes, but it'll take different efforts. So to close the gap, we must spend to reflect the needs. Furthermore, the racism that fuels the misled outrage of unfairness must be challenged. Means can also include other forms of resources, including social capital. Social capital includes relationships and networks who often share same sense of identity and support advancing individual and collective goals. So during the Voice referendum, we were contacted at CATSNM regularly to asked by non-Indigenous people what they can do. Our answer was simple: to influence the people within your social circles, your friends and your families. In her book titled Lisa's Story, Quandamooka race scholar Professor Hayley Morton Robinson articulates how racism operates within the wards of, that Aboriginal nurse Lisa worked on. She experienced a lot of interpersonal racial violence from so-called colleagues, being called names and treated terribly, and then being called more names and penalised for reporting such behaviours. Morton Robinson makes clear how the majority of non-Indigenous nurses coordinate with each other to normalise the racial violence against Lisa. When incidents were being investigated, the non-Indigenous nurses colluded to support each other's lies. Lisa would move between different wards to find a better workplace, and eventually filing a racial discrimination complaint and leaving the profession for good. When it comes to social capital, we can choose to use it to perpetuate racial beliefs to keep Indigenous peoples in check, or we can use it to transform the education and the health spaces so they're safer for all of us. Lastly, will. The will of Australians is fickle. Not all, but a number of Australians are susceptible to believing racist media coverage and political rhetoric about us. Aboriginal scholar and author Amy Maguire, in her book The Black Witness, speaks to the stark contrast between how Indigenous peoples retell stories of colonial violence in Australia and how non-Indigenous peoples tell their stories of being innocent and benevolent and being the real victim of Indigenous disadvantage. Her book tells of how the white witness is believed over the black witness, making clear the racism embedded in the Australian psyche that measures the truth of blackfellas as lower than whitefellas. At times, Indigenous peoples are also rolled out to persuade Indigenous people, to all Australians rather, that Indigenous peoples are and deserve less. And we don't have to look further than the Voice referendum campaign. As soon as the referendum date was called, the then opposition leader and his shadow Indigenous Affairs Minister focused on their attention on Alice Springs and the apparent criminality of all Indigenous people. No mention about the history or social determinants of health context that wouldn't benefit their single story, the criminality of Indigenous peoples, and with that our apparent untrustworthiness and immaturity to know what was best for us was important to them. The Voice Parliament would be defeated in the referendum, highlighting the fickle will of Indigenous peoples. We saw the changes in the poll before, during and after the campaign. The right-wing media knew that it could rely on racist narratives about us to convince most Australians. Unsurprisingly, research from ANU identified the increased racism that was experienced by Indigenous people during the referendum campaign. Research also identified that correlation between referendum votes and the health outcomes of Indigenous peoples. That is, electorates that voted more strongly against the Voice to Parliament were also electorates where Indigenous people experienced poorer health outcomes compared to electorates who voted in favour of the Voice. Our health is bound to the social political appetite of Australians, and investing in racist policies and policy campaigns, governments prove central to driving division, hate, and ultimately our poor health. And what can we do to strengthen the will of Australian people? What is the role of the nurse? In his closing remarks, Marmot challenges us with the following statement: let's dream of a fairer world and take practical steps necessary to achieve it. When we consider the size and the problem that is racism and its omnipresence in Australian history and contemporary identity, very quickly we realise that this dream can be a bit of a nightmare, with some big and scary questions about identity and belonging. Aboriginal scholar and activist Dr. Lila Watson and a group of Aboriginal activists offer these words of wisdom. If you've come here to help me, you're wasting your time. If you've come because your liberation is bound up with mine, then let us work together. End quote. Racism is part of our history and our today, but it doesn't need to be part of our future. We are bound by it as much as non-Indigenous people are. So how do we work in our separate and collective liberations together? And in this context, what is the role of the nurse? The embodiment of trust and care, apparently, but beyond improving education and health services, how do we usher our society along a better pathway? Thank you.
So where to from here? I'm on, yep, no worries, thank you. So where to from here? So this is a sobering topic, isn't it? It's a great way to start off the third day, but it's exciting because we are the future. We, across every place that we work, our sphere of influence, we, one step at a time, throwing one starfish back at a time, can make a difference wherever we stand, wherever we work, wherever we live. So racism starts and stops with us. Our sphere of influence might not be large, but it's large enough. And so I'm inviting you to make a commitment, to mobilise around conversation starters and a chance to stocktake, make commitments and recommitments. Last year I issued a challenge that said, can we have, between the Chief Nurses of Australia, the Chief Nurse, the College and the Council of Deans and us, have a day that says we stand against racism. Not because it's just something to do on a single day, but it's a day for which we do mobilise around these conversation starters and then review about how we've gone throughout the year. That we be actively alert to therapeutic nihilism in our workplaces. Be alert to stereotyping and challenge and measure our impact. You know, if you've got a high rate of discharge against medical advice in your institution, then we are not connecting with patients around what influences them and their needs. People make really rational decisions around whatever's influencing them at the time, and our job is to journey with them and try and make that planned. And unfortunately, Aboriginal and Torres Strait Islander people particularly, but not only, are absolutely stereotyped as being and overrepresented in this group, and this is our failure. So I invite you to stand with us and stand against racism. And I'd like to acknowledge the late Maggie Grant, who led a campaign with students at JCU, with medical students right throughout their training, a midwife and nurse who worked extensively in the Kimberley. Stand together against racism, against our patients, against our colleagues, and in the community. And we do that with kindness and understanding. We're not starting a war, we want goodwill. So find successful ways to do this. So please take out your phones. Righto. I'm not going to get you to put the dance music on. I think you've done quite well enough of that. But take out your phones and focus on our QR code here, because we're thoroughly modern us mob. And I want you to tell us, what action will you take against racism personally? What are you going to do in your workplace, at your home, or in your community? Do it now and it will come up on our Slido. And I want to thank you for joining us in standing against racism. It stops with us. And so as we see this, and I don't know if Nadine, if you two can see this in New Zealand, but this is, we will have a summary of this. And we're going to follow this up. We're not going to let it go. So I'm sure the college will have quite a bit to do with this. And as you're finishing that, I would like to, on behalf of my colleagues, thank you and thank the college for inviting us to speak with you today. It's a tough topic, but as I say, this is our most important safety issue in nursing and healthcare. So let's deal with it as we firmly believe in, with courage. Thank you.
An extremely important topic, and we are so appreciative of ACN for having this session this morning, and we thank very much Sabina, Ali, Karrie, Lorraine and Nadine. Thank you so much. And let us all commit to moving forward. As Ali said, racism is part of our past, but it does not need to be part of our future. I couldn't agree more.